information am I getting with an echocardiogram?
Is it
Alright, so I can get the ejection fraction. Alright, I'm getting all the information on my valves, on my heart valves, like are they functioning correctly, are they malfunctioning? I can see all those heart valves, so we see the pretty picture right there with two of them. What else? Did you say size? Okay, so we're seeing the size of the heart, the size of the ventricles. We can see if the muscle walls are thickened, like with cardiomyopathy, or we can see if the heart is too big and stretched out, like it's been overstretched. So I can see the size, the shape. I can actually see the function, like how well it contracts. That's how I get my ejection fraction. What else? I can see if there's any blood clots sitting in the heart. So blood clots like to sit up in that left atrium sometimes. There's like this little dangly bit off in the left atrium that's kind of like a little bit of a dead space where blood likes to kind of pool around and make a clot. That will be critical when we talk about our strokes later on in the module. Because we like to, and when we talk about dysrhythmias.
You say left atrium.
So there's a little space over in that left atrium that's the left atrial appendage. I don't know, it's like the appendix of the heart, where it just like blood likes to kind of pool around and get a clot in it. You can go all over TikTok and say, show me an echocardiogram with blood clot in it. There's some really cool videos where you can see people with blood clots floating around in their heart. Anything else we learned with echocardiogram? That's pretty much it.
I don't know if this like relates to that or not, but when I went to the cath lab, they put bubbles in saline and then mix it up like really fast and push it and like you can see the bubbles that like go through.
So we're actually watching how the blood flow goes through the heart. So yeah, that's called the bubble test. That's why I always laugh in validations when y'all are crying and stuff and y'all are freaking out about a bubble that's like this big. I'm like, yeah, the echo, we actually shoot a whole milliliter in there. It's fine.
That shook me when they did that.
Yeah, I was like, oh,
Yeah, they just agitate it and get a whole bunch of little bubbles. We're actually watching the blood flow through the heart. So that's how I can look at my valves and make sure my valves are opening and closing like they're supposed to. Lets me see how well blood is being pumped out. So it gives me a lot of good data. Alright, so echocardiogram, I'm getting size, shape, blood flow through the heart, valves, ejection fraction, blood clots. So I get a lot of those structural information by doing an echocardiogram. So we've got two different types. We've got transcutaneous, that's the quick down and dirty one. There's no pre-post procedure, it's just an echo. So that one's great for like emergencies, quick evaluation, and stuff like that. What you guys probably saw in the cath lab was the other one, right? All right, so cath lab, a lot of times they're doing transesophageal or a TEE. So what's the purpose of doing a transesophageal versus a transcutaneous?
Different
You see
angle.
the inside.
So a little bit different of an angle, but like it's a much better picture. Like, cause if you're doing transcutaneous, you've got ribs, muscle, breast tissue, you've got all this stuff you gotta look through to see the heart. If I go a TEE, so here's the patient with the probe, all I have to do is look through that thin wall of the esophagus. I don't have to deal with bones, I don't have to deal with muscle, I don't have to deal with anything, because the esophagus is running right up next to the heart, so there's no obstruction in my way. I can see very, very clearly. So a TEE is gonna be our best picture with an echocardiogram. And so that's what we want when we're doing the cath lab, especially if we're doing something like a cardioversion. Did y'all get to see a cardioversion? All right, we'll talk about those when we get to our dysrhythmias on the appropriate rhythms we're gonna do that for. But prior to being able to do some of those tests, you have to verify there's no blood clots in that heart. Because if you go to do some of these tests and there's a blood clot in the heart, you're gonna cause some major problems. So TEE is a very common test that we do, looking for blood clots in the heart prior to some other procedures. also, echo is what our heart failure patients are gonna get all blasted time. They get so many echoes, because if we have somebody with heart failure, we need to know that ejection fraction. Are the meds working and their ejection fraction is getting better? Or are they not compliant with their meds, their ejection fraction is getting worse? Or are they doing everything they're supposed to, their heart's just still not doing well? So we do a lot of echoes for heart failure to watch that ejection fraction. All right, pre-procedure TEE. There's nothing for an echo, so, but for the TE specifically, what's our pre-procedure? NPO at midnight, because we're sticking something down your esophagus, so we don't want you throwing up on us. So NPO at midnight. All right, we need an IV. Yep, gotta establish IV access.
Consent.
Consent. It's gonna be in the cath lab, so we're gonna have all of our equipment there in case something bad goes happen. Bad goes happen. I don't even know what that phrase.
And none of us is worried about it, we're just like, yeah.
Yeah.
Got it.
All right, so NPO, IV, informed consent, they are gonna be sedated. So they get, conscious sedation, so not go completely out, so we're gonna have all of our equipment to monitor and make sure that they're safe. Yeah, make sure they don't have any dentures in, because we're going into, so basically everything like an EGD. So if you're going to have an EGD in the GI lab, we're doing all the same things here. All right, so post-procedure. What we got? We just got conscious sedation. So what's the easy thing y'all can say post-procedure? Say, monitor their vitals. Hey, baby, breathe. I need you to breathe, because all that sedation's gonna make their respiratory rate go down. I'm not gonna make y'all know what kind of sedation they give, because everybody keeps changing it up anyway. They change up what sedation they give. So make sure people breathe after having conscious sedation. They're gonna have to be monitored for a while. Make sure their heart rate, their blood pressure's safe, O2 stats safe, respiratory rate safe.
Like conscious sedation,
Nope, we're not putting them to sleep like anesthesia. It's just conscious sedation, so you're awake, but then you don't remember anything. Yeah. So it's always really fun whenever I send students down to watch, which on y'all's TEE, were they pretty much out of it, or were they
Yeah, exactly.
fucking in? Okay, so they got good conscious sedation. A lot of times when I send people to EGDs, they don't get the good, and people are like, my students come back traumatized. I'm like, they ain't gonna remember it, they got drugs. It's fine. So we're gonna monitor them, make sure they're safe before we send them out. We're gonna let them have a steak dinner when they wake up. Because they're gonna numb up the back of their throat, so we gotta wait for all that to wear off. So we're gonna slowly let them start eating so that they don't aspirate. That's really about it. I don't think I have anything else for post-procedure. Yeah, just make sure they don't. And a lot of times it's just keeping people depending on what their tolerance was and how much drugs they had to give. And one lady that had this, like, frequently, all the time, she had to have various tests, but she was also having chronic pain and took a lot of opioids, and they had to drug her so much, had to watch her for an hour, and kept having to hit her and go, breathe, wake up. And then she'd just go right back out again, breathe, wake up, until all those drugs finally wore off. All right, yes.
Before the TE, do they need to avoid some medications? They would just only do
Just take her meds with sips of water. Oh. Yeah, that's fine. So a lot of them are on cardiac meds, and most of our cardiac meds, when we do our, looking at all the meds, they do not hold. It can be dangerous.
So they don't have to be NPO for the transfusion?
So NPO for the transcutaneous, I don't know. Okay. I was just gonna say NPO, but most, everywhere I'll say NPO, but you can take your meds with sips of water, because we're not gonna hold, we don't like holding cardiac meds. It can cause all kinds of problems. All right, cath lab. So a cardiac angiogram, cardiac catheterization, embolization, heart catheterization, all means the same thing. We just have a whole lot of words for the exact same procedure. Heart cath, cardiac angiogram, all the same. Because again, we try to be as confusing as possible. Alright, so heart cath, what information am I going to get with this test? Not really.
You wanna see if there any blockage in your heart with,
Be more specific, are there any blockages,
Narrow
arteries.
narrowing in the coronary arteries? Yes.
Narrowing and blockages or just?
All of that, yeah. So I just want us to be specific. I don't want us just to say the heart, because we're actually not looking on the inside of the heart at all. So like I can't see blood clots, I can't see blood flow through the heart with this test. Like I don't get any of that information. So with a cardiac arteriogram, cardiac angiogram, throw more words at you. I'm only getting information on the perfusion of the heart muscle itself. I'm looking at my coronary arteries. What do they look like? Are they narrow? Are they blocked? That's it. That's all the information I'm getting. So this is why it's very important to know what information you get from each test. Like I'm not gonna get an ejection fraction from this. I need to echo that. So with a cardiac arteriogram, cardiac angiogram, pre-procedure, so what did your patients have to do?
Same. NPO.
NPO midnight,
IV.
you gotta have an IV, warm consent. Alright, depending on the site has to be prepped. So what site did y'all see patients get their heart caths? Both, Loin and wrist?
Right here, right here.
Alright, so if we have, depending on where the site is, we're gonna prep the site and make sure that it is clipped. We don't like to say the word shaved anymore, to use the little clipper things. So we're gonna pick a site. So the site's gonna be determined from the healthcare provider, what their vasculature looks like. Our preferred is going to be the arm, because there's less risk, less invasive, so we want the arm, whether that's through the radial, through the brachial. But the gold standard is still always gonna be the groin, because that's the biggest vessel that you have, and it's the easiest access. But it also comes with the most risk with this procedure. So, but they're gonna pick whichever site is gonna be the best for the patient. So, they're gonna go in, let's do, since the groin has the most risk, let's talk about that site, because that way we can hit everything. So, but all this stuff applies to both. That's really about it with pre-procedure, NPO, consent IV. What over meds?
Yeah, like what they said that morning.
Yeah, so some education, like basic history intake kind of stuff. So they're gonna go in through, we're gonna say they're gonna go in through the groin site. They're gonna be looking up, you see the catheter goes all the way up through the aorta, and it's gonna be looking at the vessels. Did you guys see anybody with some narrowed vessels? Yeah? Did y'all see them get fix it?
No, it's not narrowed enough.
Alright, so a little bit of both. You got to see them fix it or not fix it. Alright, so for this content, for 114, we're mainly going to focus on just the test, looking at it. So when they do the corrections, like they place the stents or stuff like that, that's going to be 211. So we're just going to go over the procedure. We're not going to go over like the stents and stuff like that.
You know, into 11 if we go back to the back.
No, you don't
Don't
get to go.
get to go.
You don't get to go back. Cat lab's just a one experience type thing.
That sucks. I love it.
Yeah.
I thought it was.
I like it. A lot of fun on that.
So you guys get a great experience because the Shelby Cath Lab are used to us, like they know y'all come all the time and they're really good. Not all hospitals are the same, so some of the other campuses that go to the Cath Lab basically don't get to do much of that. And I'm like, shh, we're staying at Shelby. Did y'all get a great experience at Shelby? I love it. Alright, so they're gonna go in through the groin, look around, look for the vessels. If they can fix it, open heart surgery is definitely gonna be 211, so not gonna do that. Okay, so while we're doing this, role of the nurse, what did you see the nurses doing during the cath lab? Do what?
Moving the screen.
Alright, so,
Not
not a,
tell them to put it a different angle and they would move it down.
yeah, so really just, hey, what y'all need while we're doing this? Yeah, they're watching the vital signs, so maybe watching the rhythm, that's really about it.
It's like a sterile nurse, and there's one on the screen.
Yeah, so not, they're kind of on the sideline, so not a whole lot during procedure. Now, post-procedure, we got a lot of stuff that we gotta do post-procedure. So again, let's talk about the groin site, and let's talk about post-procedure.
The one running the screen and stuff, the rad tech, right?
Oh, is it
Like,
that?
Yeah.
I don't know, it's probably somebody running the fluoride machine.
I mean, there was.
Or
Or people said that it could be a rad tech or a nurse, but they have to be certified on the machine or whatever.
A lot of crossover in the OR with various things. We got a surge tech program now, so we do all kinds of stuff. Alright, so post-procedure, we're gonna say your patient comes back from the cath lab, they had a groin insertion site, and you are the nurse that is now receiving this patient. What position are we gonna keep this patient in?
Flat.
We're going to keep them flat for a predetermined length of time. So it depends on how they closed up the groin site, whether they have to lay flat 2 hours, 4 hours, 6 hours. So they're gonna have to lay flat for a period of time. There's all different kind of ways they can close it up, which changes that time frame.
Who determined that time frame?
The doc, with how they close it. Sometimes they stitch up that artery, sometimes they leave it wide open because they're afraid they may have to go back in. Sometimes they fill it with this crap that's like Fix-A-Flat, that just seals it up. So there's a lot of different ways they can close this artery, so that's how they determine 2 hours, 4 hours, 6 hours. So we just gotta look, what's my time frame? So we're gonna lay flat for whatever order of time that but we know it's gonna have to be some period of time. Alright, if they have the catheter completely removed, or they don't, so we're gonna look at that, because a lot of times they come back with the catheter in place. Did y'all see nurses having to pull the sites?
Yeah.
Alright, so mixed bag, some of you did, some of you didn't. So that also depends on how the patient does, whether they pull the line in the cath lab or they leave it in place for the nurse to pull afterwards. So we're gonna be checking blood clotting. So doing some lab draws to see how thin their blood is. Because they give them blood thinner in this procedure so that they can clearly see all of the vessels. So the nurse may have to pull the catheter. If they have to pull the catheter, it sucks, because how long did they have to hold pressure?
20 minutes. 20 minutes.
Yeah. Sometimes if their blood's real thin, you're holding pressure for a long time, and it's not fun. I hate pull, that's my worst. I hate it more than anything else. I'd rather do chest compressions on a whole person than pull a line. I hate it, because you're just, have to stand there with pressure, it's awful. So we got hold pressure. A lot of times post holding pressure, what did you see them put on the site? Roll rag, yeah. So a pressure dressing. That was a pressure dressing. They either roll up a rag and put it really tight on the site, or some hospitals have little clamps that go onto the bed that actually compresses down on the site. So we're gonna have to hold pressure, because this is an artery, and they give them blood thinner. So can they bleed out quickly? Yes, they can. Alright, so pressure will have to be applied until they stop bleeding. So there's no damage. Nope. Depends on how thin their blood is.
How often are we checking those labs, or are we just kind of?
It depends on what blood thinner they got, because if we're doing a PT, PTT, or what's the other one, ACT or something. So it depends on which blood thinner they got in the procedure.
Okay.
So some type of blood thinner test, some sort of coag test. And they have the little machines, just like iStats, that they run like just right there. They don't have to send it to the lab. Alright, so we're gonna hold pressure, we're gonna keep them flat. What assessments are we gonna make? Alright, so we're gonna do neurovascular checks on bilateral extremities. So we're gonna make sure the pulses are the same. We're gonna make sure the temperature sure the color of both legs are the same, because we're going into an artery, so we can damage the artery and damage the perfusion to the legs. So we're gonna make sure the legs look the same. If the procedure leg suddenly goes white and I lose my pulse, I got big, big problems. So I would like to catch that as soon as possible to try and prevent any damage, so they can go in and correct whatever issue's going on. So I'm gonna monitor both legs, and that's typically your standard kind of recovery time frame, so like every 15 minutes for an hour, 30 minutes for an hour, you know, kind of like your standard post-op vital signs. You just do pulse checks, temperature, color checks on the legs. What about the site? What are we looking for? What are we assessing for?
Where?
Bleeding, yep, we're looking at the site for bleeding, so obvious bleeding, like it's bleeding at the site, but how would you know if it's bleeding underneath the skin? Bruising, what else? Getting bigger, so hematoma. Looking for hematoma development. So if my patient starts saying, it's getting really tight down there, let me look at it. I don't want a hematoma developing on there. If you see a hematoma or bleeding developing, what do you do?
Push it?
Pressure. Pressure. Yes. Pressure. If they're bleeding, apply pressure. So if we see a hematoma developing, if we see bleeding occurring, we're going to apply pressure, because again, it's an artery. Apply pressure so they don't bleed out. Alright, so we're watching for bleeding, watching for bruising, watching for hematoma development. Watching to make sure the legs are bilaterally stable. Now the wrist and the arms, much less problems. I mean, it's so much easier of a recovery for the patient, less work on the nurse because they just don't have a whole lot of complications. Smaller arteries, so you don't have to hold pressure quite as long. So, but we're still gonna be monitoring to make sure bilaterally the hands are still same color, same temperature, you know, holding pressure. So, but it's so much less invasive than the growing, 'cause it's just such a big artery down there.
When they go through the rest, after the procedure, they put like this bracelet on.
It's a pressure bracelet
How long does that stay on there until like?
until the bleeding stops. And always till the bleeding stops. So yeah, they monitor and check it and see if it's still bleeding. Nope. You get it for another 5 minutes or so.
So arm is quicker, it's like.
Yeah, it's much better to go on the arm because there's less risk. And it's just easier on the patient. They don't have to lay flat if it's in through the wrist, because we just have to lay flat because of this huge artery that we're going into. So it's much easier on the patient, it's much easier on the nurse. But not everybody's got good vasculature that we can do that. All right, there's one more big risk with this, going into the groin sites that we're gonna monitor for. So this rarely happens, but it is a potential complication. They're going in through the groin. What if they miss this curve and just go boop, and pop through the side of the artery? Where are they gonna bleed out at? Their abdomen. How are they laying? Flat. Are you gonna see anything? No. What is the patient gonna feel? So they may start feeling like lightheaded, dizzy because of hemorrhaging. The only symptom they typically complain of is unilateral back pain, because that blood settles while they're laying flat. So if the patient complains of back pain, we're not too alert with it because they're having to lie on that hard table, so it's uncomfortable. So, but if they say just one side, like the procedure side of their back hurts, in this area up here, so kind of like, not quite up where the kidneys are, but, you know, kind of above where your hip bone is, where we kind of expect some uncomfortableness to be. So if they're saying unilateral back pain, that's concerning. The only way we can see is sending them down a CAT scan, and just doing a CAT scan really quick, because you can see the blood pooling in the back of the, so that's called a retroperitoneal bleed. So retro back peritoneum leak. So it's a big risk with the groin access site.
How you spell that?
Retro. Got that one?
Got that part.
All right, peritoneal, so P-E-R-I-T-O-N-E-A. Did you get the little red squigglies or did it work?
Got it. No red squiggles.
The red squiggles. Have to see it in my head. All right, so that's the main thing. That's like kind of like the big complication that we worry about with going into that groin site, is having that bleed. Because that is a medical emergency. They've got to go to the OR and get it fixed. We're not doing that now. Not doing that now. Okay, cool. So that's all of our diagnostic tests. How do we feel about diagnostic tests? Feel pretty good? Kind of help understand the cath lab a little bit, if you've already gone. All right, those of you that haven't gone, now that you've had the content, be looking out for it while you're in the cath lab. Okay, so now, let's do decreased cardiac output. So we're going to, here's our little fella. So he needs a name because we're gonna make him our decreased cardiac output guy. So y'all gotta come up with a name for him. There's been creative names and then there's just been boring names. Y'all can decide what his name will be. But he's going to be our decreased cardiac output, worst case scenario patient. So we'll come up with signs and symptoms. So with you friends, again, don't look in your books and resources, see what you can remember out of your own brain, because obviously your resources know when they're just gonna tell you. So think back using your own brain. If my person here, to be named later, has decreased cardiac output, what signs and symptoms is he going to show me? Okay, so you're gonna give me signs and symptoms, and we're gonna put them up here, and then we're gonna have interventions over here. So 5 minutes, y'all come up with signs and symptoms, and then come up with some interventions for somebody with decreased cardiac output. Do not go into like chest pain and heart attack worlds, so kind of stop before you get that far, okay? Hey, go. But you may name him in your heart, whatever you would like to name. It can be in your heart. Yeah, from that Fred. All right, so Fred for short, because it's a lot. What symptoms is Fred going to show us if he has decreased cardiac output?
Bradycardia. Oh, so you
All right, so I'm actually going to make a little adjustment. And I'm going to say a lot of times the heart rate being low is what causes the decreased cardiac output as opposed to a symptom of. So, because we have a lot of tachycardia issues. So I'm going to say, in general, the heart rate is usually going to be elevated because the blood pressure is typically low. Alright, so bradycardia absolutely can cause decreased cardiac output, but for the most part, we're going to stay a little bit more broad, a little bit more general, and typically the signs are going to be low blood pressure, which causes a compensatory tachycardia. Okay, tell me more. What else?
Like dizzy or lightheaded
Alright, so we're going to be dizzy, lightheaded. If it progresses,
Pass out.
yep, so what's our word? Syncope. Alright, so we get doing get lightheaded, we can pass out.
This new.
Okay, we're gonna stay short of breath. So what's your respiratory rate gonna be? High, so we're gonna have an elevated respiratory rate. What potentially can your O2 stat do? Drop. We'll say, or normal. It could maintain, like if your respiratory status is really good, you could maintain a good O2 stat with this, but it potentially could drop. What else? Alright, we're gonna be tired because we're huffing and puffing and we're real dizzy. Lightheaded, so we're gonna be tired. What else?
Okay.
Alright, so skin changes. We're gonna be pale. What else, skin change wise? Okay, so we can be pale to cyanotic. What else with skin changes?
The capillary refills.
We're gonna say poor cap refill. So we're gonna try and do cap refill, and it's gonna take 5 to 6 seconds rather than our 3. So very slow on our cap refill. What else skin changes?
They're gonna like cold, because pores.
They can be cold to the touch.
Heart sounds.
I'm still with skin though. We'll stick with skin until we get all the skin stuff. So cold to the touch and clammy. So they made, what other word? That's the big long word that I have. Yeah, diaphoretic. Alright, cold, clammy, pale, diaphoretic. So a real nice, sweaty, pale person that's dizzy and lightheaded. Okay, now we can have more things other than skin. So I don't know about what's different with heart sounds though.
Do they have edema already?
They can have some edema, like dependent edema. If all their blood's just kind of sitting down at the bottom. Yeah, so just ankles, feet. Not really whole body edema, just like some dependent edema because it's not coming back up to the heart. What else? Poor cardiac output.
Palpitations.
Okay, so they can have, let's go here. Let's say EKG changes. Because we're gonna get into that a little bit more. Because like the feeling of heart palpitations, you can actually see them on their heart rhythm, like with your PVC and stuff like that, so we'll get into that. So we're gonna say EKG changes, and that you can feel some of those.
They're not getting blood in the kidneys, so they're out like the urinary issues.
Decreased urine output, because we have already learned that when you have decreased cardiac output, you can go into acute kidney injury, so you can go into AKI. Which type, pre, intra, or post?
Pre.
Pre. Yeah, pre. I was hearing pre and intra both. Remember, intra is damage to like the glomeruli, stuff like that. Not getting perfused is gonna be pre. So we're gonna put this up here. Pre-renal. AKI. Decreased urine output. Fun fact, every person that experiences cardiac arrest, which is the worst case scenario, decreased cardiac output, all go into some type of pre-renal AKI. Just, is it really bad or is it not too bad? Happens to everybody because you don't get perfusion down to your kidneys. Let's see, anything else we want to put on here? Start refill, leaking through any pulses.
You get confused because of the, like, factor.
So, you say confusion can be up in here. We're gonna put it right above CGP. I don't wanna put it below because we're already passed out. I don't know if we're confused. So I'll put it up above. Anything else we wanna add?
Altered mental status.
I think we kinda got it with confused. So yeah, just altered mental status covers that. Anything else? Alright, what are we gonna do for this person? So we've got, drop dead Fred over there. I don't want him to drop dead. So what can I do to prevent that from happening and just leave him to spread? Huh?
Stick in the bed.
Alright, so we're gonna get him on bed rest. I do not want him getting up and running around right now while he's worst case scenario because I don't want him to hit the floor. So we're gonna put him on bed rest. What position would I like for him to be in? Alright, so we're gonna say semi Fowlers if one parameter. One vital sign over there is gonna tell me if I'm gonna put him on semi-flat Fowlers or if I'm gonna put him flat.
The blood pressure.
Ooh, it's a debate. O2 and blood pressure. O2 and blood pressure.
Blood pressure.
O2.
Semi Fowlers if BP is okay. We're gonna lay him flat if BP is low. I can always throw oxygen on you while you're laying flat.
Oh, no,
Alright.
that was the question, Marcy.
Alright, if their blood pressure is low, I have got to lay them down because I need perfusion to the heart and the brain. So if their blood pressure is very low, I need perfusion to the brain, so I'm going to lay them down flat. If their oxygen is low, I'll throw an oxygen mask on it then and get them some extra oxygen. But we're gonna get more into what we do and how we treat this with the position changes with the blood pressure when we do medical emergencies. Okay, so this is coming back in medical emergencies. But for right now, just initial assessment. If their blood pressure is okay, I want them left up because I want them to be able to breathe easier. I want better venous return coming to my heart, so I would like them sitting up. But if their blood pressure is low and they're very dizzy and lightheaded, I want that head of bed flat so that I can perfuse their brain and their heart much better. All right, what else am I gonna do for this person? I already said it, so I'm just gonna put it up there. O2 if needed. What else do I want to do for this person?
Heart monitoring, like EKGs or telemetry.
Alright. So I want to monitor their rhythm. What rhythm are we in? Are we changing rhythms? Are we going back and forth between different rhythms? What rhythm are you in? So I'm going to monitor that. What else?
And taking out fluid.
Thank you. I was like, y'all gonna care about some fluids or something like that? Let's talk about some fluids.
I just said, would you give fluid?
Alright, I'm gonna say I equal O just to say that we need to maintain fluid balance. So if we are low on our fluids, let's give them some fluids. If we're having like crackles in our lungs and stuff like that, we probably don't need fluids. So we wanna make sure that they are hydrated, that we have adequate amount of fluids in this person. And a lot of times they need a little boost, a little extra bump. What else we gonna do?
Fall precautions.
So I'm gonna put that right here and say, They are a fall risk, they're a pass out risk, and we do all the good fall precaution stuff. We don't want them getting up, especially unmonitored as we improve this. So we're gonna get more with that with medical emergencies. We're gonna keep it basic. Bigger on the road. All right, so we're going to, so we said meds, we're going to treat, going back to the telemetry, treat, heart rate as needed. We'll say beat beating. So we said earlier there may be an issue with bradycardia, so we would treat that accordingly. We may have an issue with low blood pressure, we can treat that accordingly. So we have various medications for all ways of going ups and downs with heart rate and blood pressure. So we're just gonna say treat as we see it, because that's a big part of what we're gonna be getting into this afternoon and next week, is getting into all the EKG rhythms and how we treat those. So we'll just say treat as needed. All right, so those are kind of like the big ones. The other things are kind of like, you know, a little bit smaller. Like we want to cluster their activity together. We don't want them exhausting themselves. So, you know, try and decrease the amount of things that they have to do. You know, decrease stimuli, decrease things that they have to, you know, just put forth some effort to doing. When we get into anemia, we'll talk more about like nutrition, things like that. So this is kind of like our, just kind of basic emergency type decreased cardiac output treatment. So anemia is really where we're gonna get into like the living with this and trying to keep them safe on a daily basis. Alright, so let's take us another break and decide what I want to get into before lunch. We're done with our overview now, but anemia goes literally right along with this. It just matches up so well. So we're gonna go ahead and do that, and then cover hemophilia because it's like super short, so not very much. All right, so anemia. There are, ready to type? 1, 2, 3, 4, 5 different types of anemia. Anemia is anemia is anemia for test purposes. Okay. So when you're reading all the different types of anemia, just kind of group them together. So we have different ways that you can have anemia. So some of the different ways you can have anemia would be nutritional deficiencies. So like you guys have heard of iron deficiency anemia, right? So that's one of the types. Our kidney failure patients have anemia. Why do they have anemia? They're not making up erythropoietin, so they have anemia. We have some genetic disorders that cause the cells to die prematurely. There's other genetic causes that makes the cell just not last as long. Those are different types of anemia. So we have several different ways of having anemia. But essentially we're going to treat them mostly the same. There's some really detailed nuances to those, and we're not going to get into that. We're going to kind of stay broad topic with anemia. I do want you to take sickle cell anemia and pull it out of this conversation, because honestly that needs to be renamed to something different, because sickle cell anemia is so different from like your standard anemia. So if you'll just put a little star, we're going to talk about that next week, because I've got like a whole VSIM case study that we can get into and talk about the medications and stuff like that. So we'll talk about sickle cell later. So if you look at your symptoms of anemia, let me kind of look like Fred. Yep. So we'll kind of point out the differences. So basically your signs and symptoms of anemia are signs and symptoms of decreased cardiac output, because you don't have enough red blood cells floating around. Whether you don't have enough blood cells because you're not making enough, because you're having nutritional deficiencies, or because they're being destroyed prematurely. Whatever reason, you have decreased cardiac output due to anemia. You can potentially have some yellowing, like some jaundice, because the debris of the red blood cells, like if have that type where your red blood cells break and get destroyed prematurely, you can have some of this jaundice yellowings going on. Worst case scenario in the red, because worst case scenario right here. So if we have decreased cardiac output, we can have some of these issues, which we will get into next week. So in general, signs and symptoms of anemia and signs and symptoms of decreased cardiac output. So we said this is like the emergency kind of care for that. So let's get into the daily care. So if somebody has anemia, what are we gonna teach them? Because most times they're living with this. So they're going home and they're in a chronic state of anemia. What are we gonna teach them on how to keep themselves safe? Do it?
She said iron supplements.
Okay, so let's talk about nutrition. So they need to add some things to their diet. What do they need to eat?
They eat red meat.
So they need to eat things that have good B vitamins in them. So red meats, things that have iron in them. So high iron diet. If you can't get it in natural food, you take supplements. What kind of supplements would be a good idea? So we said B vitamins, iron, what's one more thing? Folic acid, folate. So those are all to promote good red blood cell production. So they can take either supplements or they can increase, I mean, I don't like things that have iron in them. Not a chicken liver kind of girl. So I would need to take a supplement. Alright, so nutritionally, we want to increase like our red meats. We want to make sure we're good and hydrated. Hydration, hydration, hydration. So if we don't have enough red cells, we at least want to have enough volume. Okay, what else can we teach this person to keep them safe? They need to jump up out of bed really quickly. No, what do they need to do? Yeah, change position slowly. You know, we don't want them to get head rushed and pass out. So just be safe, change position slowly, get acclimated before you just jump up. What else? They need to go to the grocery store, clean the house, go pick up your kids, go to football practice, and do all those things all at the same time? No, so we need to teach them to space out their activities and allow break time. They need rest. So they can try to group as many activities together as they can that are kind of small, but they need to make sure that they're working rest into their day. Especially rest for hydration breaks. Make sure they stay hydrated and rest. We need to teach them how to recognize when they're starting to have tachycardia, because that is one of the first signs. Increased respiratory rate and tachycardia are some of our first signs that we're getting symptomatic. So if we need to teach them when they start feeling themselves, their heart racing, they're breathing a little fast, that's a sign that you've overdone it and you need to sit and take a break for a little bit and rest. Maybe get you something to drink. So we just really need them to learn how to monitor their own body and adjust as needed. Which is really hard to do if you're running around with kids, and school and job and all those things. So they gotta be in tune with their own body and take care of those things. Yeah, so we wanna hit them, we want them to take rest before they get to that like palpitation and pain level. We don't want them to get that far. So if they start feeling their heart rate's going or they start feeling that they're breathing fast, those are early signs they need rest. What medication can they take if it's severe?
Iron.
Okay, so we said they can take iron supplements, but what medication that's a shot that they can take if they have
Epoetin
severe
alpha.
anemia?
Epoetin alpha.
Epoetin alpha. Fake erythropoietin. So we already said they can take iron supplements. They can take EPO if it's severe. That's a nutritional issue. So they definitely need to increase. So they can also take B12 shots to a B12 deficiency. Other things that I put on here was just like increased protein, that kind of goes with that too. Yeah, they get constipated really easily, but we talked about making sure they stay hydrated and lots of fluids, so constipation is a common issue. You know, blood goes to organs as opposed to guts and skin when it's on the low end. Yeah, that's about it, what I got with anemia. Not a whole lot. Pretty basic, because I'm not making y'all get into all the different, anemia types. Hemophilia, this one's pretty short and to the point too. So hemophilia, I've got hemophilia A, hemophilia B, I'm not gonna ask you the deficiency that it's in, because that's more healthcare provider, level. There's also a third type that's got a little, real long wonky name, but it's a type of hemophilia. So just know when you're reading, you have types of hemophilia. We're going, again, just like with anemia, we're going broad spectrum hemophilia, okay? So hemophilia is a genetic disorder. It is a recessive gene disorder. So it is on the recessive gene. It is on the X chromosome. So ladies, we have XX. So if you have the hemophilia on your X chromosome, but you do not have it on the other X chromosome, are you gonna have hemophilia? Nope, because it's recessive. But what are you gonna do? If you have children, you're gonna pass that, you potentially are gonna pass that trait on to your children. Boys, it's on the X chromosome, it's recessive. You ain't got another one to dominate it out, so it mainly affects our boys. Rarely ever see it in girls, but mamas, you can pass it on down to your kiddos. So predominantly we see it in boys. It is much more, so same thing as sickle cell, so everything I'm saying with sickle cell is the exact same thing. And we see both of these more commonly in African Americans than we do any other ethnicity. Yeah, with both of them. So everything I'm saying with sickle cell goes along with this too, so I'll be repeating this next week. So there's different levels. So with hemophilia, you do not have a clotting factor. So we know there's a clotting cascade, right? One thing triggers something else, which triggers something else, which triggers you to blood clot. So with hemophilia, it's a recessive genetic disorder, and one of your clotting factors are not made. So the coagulation cascade just stops. And then there's differences in which factor it is. We're not worried about that. So there's different levels. You can have mild, moderate, or severe. So I'm not getting into the amounts and everything. I'm more into what we see with the patient. So with mild hemophilia, these people may go their entire life and have no idea they have hemophilia. Because they just may be an easy bleeder and they don't think anything about it. Or they may have surgery and have trouble clotting after surgery, and then we discover they're a hemophiliac when they're like 40, 50 years old. So milds potentially may not know because they just don't really have any symptoms. Moderate, you see, we start having some hemorrhaging secondary to trauma, and we have an occasional spontaneous bleeding. These folks typically know they're hemophiliac because they may have a spontaneous bleeding. But we're gonna go severe. Severe guys have spontaneous bleeds. So a common place to have a spontaneous bleed is going to be in the joints of the legs because that's where you're putting all your weight. So there's more risk of tearing different little capillaries. So knees are very common as you see in this picture. So spontaneous bleeds in the joints is where we most commonly see those. pretty young for somebody with severe hemophiliac when they have their first significant hemorrhage. So with these folks, if they start having a severe bleed, what do they need? The clotting factor that they are deficient in. So these patients are gonna know their hemophiliacs, whether they're AV, whatever. They're gonna come in for a bleed, doc's gonna order factor, whatever they're deficient in, and we just gonna give it. So that's why I say I don't really care that y'all know which factor that they need, because that's a medication specific order. So they need their factor. No amount of pressure is gonna make them clot. They need their clotting factor so that they can actually stop clotting. So our severe folks, they're gonna be going home with their clotting factor. Like, they're gonna keep this at home.
Is it like a blood product, like it's in a?
It's a med.
Bag? It's a, okay.
It's just a medication.
Yeah.
So you can actually teach the parents how to start just like a little butterfly catheter, straight to the vein to inject their clotting factor.
So do we need to like go that deep, like worry about the route?
IV is gonna be like for our really severe folks,
Okay.
they can do IVs. So for our education, we would have to teach the parents how to obtain IV access. And it's not like starting a full IV, it's literally like sticking with a butterfly and connecting it up to a syringe and infusing it. So teaching the parents how to safely access the IV, you know, make sure everything's primed up so that they're not injecting air, keeping everything clean. So we'll teach the parents, and then as the child gets older, we'll teach the kid how to do that too. So that's worst case scenario. So they're gonna keep that at home. So if they start to have a bleed, they can go ahead and get their clotting factor on their way to the hospital. So that they can get more clotting factors. That would be preferable, so we know what kind of hemophilia that they are. The bracelets would be very helpful. Alright, so, and then we're gonna treat symptomatically. They need their clotting factor. If they've hemorrhaged and they've lost a lot of blood, obviously we're gonna treat that just like we would anybody else. They get blood products a lot, unfortunately, if they're severe. If they bleed out into a joint, we want to be very careful to try to mobilize it as much as possible so that they don't have any further damage. Most times, we want to try and let their body reabsorb it on its own, but a bleed that significant probably is gonna have to get drained so that there's not permanent damage to that joint. But we would prefer not to have to surgically intervene on these folks if possible.
Immobilize the joint?
Yeah, we wanna keep it steady because we don't want any more tearing going on in the joint to cause more bleeding. Do we want heat to that? No, we don't wanna bring more blood to somewhere that's possibly torn. So we're not gonna put any heat packs on it. We can put cool packs or ice packs, but they don't need to stay, so it's just like 20 minutes on, take it off. And that would just be for some pain relief. So, elevation, trying to again help it reabsorb a little bit better. So kind of your standard, the price, standard stuff. We don't wanna put too much compression on that, because what can happen if we compress that too much? bleeding out, we just treat them like anybody else that bleeds out. Place the volume, give them blood, and they gotta have their clotting factor. Clotting factor, clotting factor, clotting factor. Alright, yes, see, that's true at this point. Any other questions with anemia or hemophilia? Okay, cool. So, we're gonna break, we'll come back at 12:30, and we're gonna start EKG stuff. So they move to this PowerPoint. So if you're following along on PowerPoints, we move to a different one. Alright, so we're gonna start talking about EKG rhythms and how to interpret an EKG rhythm. So there is a lot of variety of knowledge in the classroom when it comes to rhythms. Some of you guys may already know all these rhythms I'm gonna teach. Some of you guys have no idea what a P-wave is. So we are starting all the way at the very beginning, and we're all gonna start from the same introductory level point on what is a P-wave. So I've given everybody a worksheet, because we're gonna be labeling this worksheet. We're gonna talk about what each one of these things are, define it, how to recognize it, understand what it's actually doing, so we're starting at the very beginning. So before we can even get to the rhythm itself, we gotta start with, we gotta put some leads on the person. So I do not care that you guys know, like for test question purposes, where the color of the leads are on the person. Because every single time you will ever be putting leads on a person, there's gonna be a little picture that's gonna tell you how to do it. Follow the picture. Okay? However you would like to learn that. But what I do want you to know is when you're putting leads on people, you need to make sure, for one, you're not putting it on a real hairy spot. Because if you put it on a real hairy spot, you're not gonna get good readout. So you need to clip the chest, clip the chest. Do not put it on somebody that is wet. So if they are very diaphoretic and sweaty, or you've just coated them up with a whole bunch of lotion, you are not gonna be able to get a good reading. So it needs to be dry, non-hairy areas. So try and pick your locations wisely. Preferably, if you've got somebody really, really skinny and really, really bony, try and get in between ribs. Don't put it straight on a bone. So if you've got some really skinny folks, try and get in between in that intercostal space. Also, you can get a nice, clear printout. Okay? It's going to print out on graph paper. So as you see, I've got graph paper here. The printout that I gave you is on graph paper. So it is on graph paper so that we can measure a lot of different intervals and different waves, which we'll go over. So the graph paper, if you notice on here, we've got big boxes and we got little boxes. When I'm talking about a box, I'm going horizontally, okay? So from this is a big box right here. So from here to here represents 0.2 seconds. So I'm going to be calling this my big box rule. Now there are some very, very specifics when you're talking about interpreting all of these rhythms. I have simplified it. So the rules I'm going to give you are going to be a little bit more general than what a textbook is, because again, this is basic dysrhythmias. So if you learn the basic, you can dial it in when you get to advanced a little bit later. But I've just tried to simplify it. You know, this is EKG rhythms for dummies, okay? Like that's the level I'm going for, just to try and help you very basic understanding. So big box is going to be from here to here. This length right here. So that's my big box. It's 0.2 seconds. The little box is 0.04 seconds. So you've got all these little boxes in here. Those are 0.4. So that's how you know the seconds. From start to finish, this is going to be a 6-second strip. That will matter. Every strip I give you, whether it is on a paper, the worksheet, because I've got 30 rhythms loaded on Canvas that you can practice on. Every one that I give you, every one I give you on a test will be 6 seconds. Because that's how we're gonna determine our heart rate. Because there's a really complex way to determine the heart rate, and there's a really easy way to determine the heart rate. Which one do you want? Easy. An easy way. Good, because I couldn't explain to you the hard way even if I wanted to, because I'm blocking down my memory. I don't even want to do it. It's too much calculation. start to finish. Alright, so, so let's start looking at and defining these waves, and then we're gonna talk about what's actually happening in the heart. So, if we look at our rhythm that we have right here, we wanna label it. So the first thing is a P wave. So if you already know, go ahead and label it. But the first wave is a P wave, which is this tiny little bump right here. This is your P wave. Tiny little bump. Go ahead and label it. P wave. P wave. P wave. P wave. Alright, so that's what it looks like. QRS complex. So let's label Q, R, and S. So you see how we've got the P wave, and then it comes over, we got a little space here, and then on mine, it kind of juts down low a little bit. Okay, that junction right there, before it drops down, that is the Q. Okay? Where it leaves the baseline. This is our baseline. Where it leaves the baseline, and on mine, it dips down a little bit. On yours, I think it just goes straight up. Does y'all just go straight up? It all goes down a little bit. Alright, so this junction where it leaves the baseline is the Q. Not that low point. It's where it leaves the baseline. Right there's the Q. It's gonna go down, and then pop back up. This tallest point, R. And then we come back down, we kind of bottom out, but where we come back to baseline is S. So Q is where we leave the baseline, R is the tallest point, and the point can be pointing up or pointing down, either way. The tallest point is the R, where it comes back to baseline is the S. Now on this one, it kind of goes up and goes down a little bit. You may have one, as we're gonna see, because I got a lot of examples, it may go up and go down significantly, but it's where it comes back to baseline is the S. Alright, then you got a little bit of section of baseline there, and it gives you another little hump, and that's the T. So now we know what all the waves are called. Second hump is the T. Alright, so check your friends. Everybody should have, if I do this one, we should have P, Q, R, S, T. T is right there. Oh, it's so light. That's my heart. Isn't it beautiful? It's great. You got 4 chambers in your heart. There you go. What's the top chamber called? Atria. What are the lower chambers called? Ventricles. Let me get all my pretty color markers because we're going to say what all these things are doing. Highlighter get in there for? Who tells your heart to beat?
SA.
The S-A, no. Thank you, y'all did not say your brain. Your brain does not tell your heart to beat. How does your brain affect your heart rate? Tells it to go up or down based on a variety of factors. But it does not tell your heart to beat. So if you chop off somebody's head, their heart will continue to beat until it runs out of oxygen, because your brain does tell your lungs to breathe. So, if we don't have a brain, we don't breathe. But your heart will keep beating until it runs out of oxygen. So the fun kung fu movies where they like rip somebody's heart out, or like Indiana Jones, Temple of Doom, heart still beats in their hand. True to life. That's real. Heart will still beat. I actually got to see that one time when we had a organ donation, because they keep the patient, like the heart beating, the patient's been pronounced brain dead. They keep the heart beating, so I actually saw them take the heart out and sit it on the counter and it's still beating. I was like, oh my gosh, the coolest thing I've ever seen in my entire life. It was so cool. So, SA me know that your SA node sent off that impulse. So your P wave is going to represent, so we're talking about electrical activity here, that's all I'm saying, electrical. So what does a muscle do electrically before it contracts? Depolarizing. So your P wave represents atrial depolarization, and it tells me the SA node fired to the AV node. That is what your P wave is.
Before the actual part contracts, it's just the firing of the impulse.
So everything on this rhythm strip is electrical and electrical only. That's what we're evaluating, the electrical system through the heart. I am assuming once a muscle depolarizes, it then contracts. But everything that I'm evaluating here is electrical and electrical only. This is why it's so important. If you see a rhythm that somebody looks like they're dead, what do we assess? A pulse. Because it's two different sets of functioning in your heart. The electrical system could function, but the rest of it may not. So we'll get into that a little bit more in detail. All this is electrical, so we're going to use electrical words. Every test you will ever take on anything EKG related, there will be a question. What does the P wave represent, or the QRS represent, or the T wave represent? And there will always be options that say muscle contraction, and it will be wrong every time. It is depolarization or repolarization when we get to when it's got to get ready. So use your electrical words and your electrical words only. All right, tell me what SA node stands for.
Atrial.
That sounds like the word sinus, doesn't it? I've heard the word sinus. So if you have a P wave for every single one of your heartbeats, you can use the word sinus. So you cannot use the word sinus if you do not see a P wave. Not allowed. You don't get to use the word. So if I see a P wave, I get to say the word sinus. Because I know the sinoatrial node worked. Cool. Moving on. Where does it go from the AV node?
Bundle of his,
Bundle of his to the
Mackenzie fibers.
not quite.
Bundle of what? What?
Bundle of his.
Where is that at?
It's like a little tiny EV fiber. And this is all we're going to say about it. Like, we're not going to say anything else about it after this. Just a little bundle. Then we're going to go down the right and the left bundles. That's on each side of the septum. SA node to the AV node to the bundle of his. And then down the right and the left bundles. That's on each side of the septum. That's all I'm going to say about them. Because they don't have any other function. All right, and then they go up the whole rest of the ventricle, and what are these called? Purkinje fibers. I spelled that all wrong, that's why I flubbed it. Purkinje fibers. All right, so now let's come back over here. What's the rate of your AV node? 40 to 60. Wow. I was writing cardiac output on there. 40 to 60. Because if something takes out your AV node, are you just going to give up? Your AV node will take over. If something takes out your AV node, your Purkinje fibers will take over. What's their rate? We went from 60 to 100, went from 40 to 60. What do you think? 20 to 40. 20 to 40. 20 to 40. All right. So now we got to get back to our waves. We got to tie this together. So that was the P wave, just the SA node firing to the AV. All of this going through the bundle of his, going through the right and left bundle branches, all of that is your QRS complex. Your ventricles are more important, they get more letters. Okay. You can live without your atria, you can't live without your ventricles.
You said the QRS starts at
It goes, it's all the bundle of his, the bundle branches, and the Purkinjes. So over here, the QRS represents what?
Ventral repolarization.
Ventricular depolarization. Now, your atria and your ventricles think like this, right? So while your ventricles are depolarizing, what is your atria doing? Repolarizing. We repolarize or we rest to get ready for the next round. So we're going to depolarize, contract, and then repolarize to get ready for the next round. All right, we have one thing left, the T wave. What do you think it represents? Who's the most important, atria or ventricles? Ventricles. So what does the ventricles got to do? Repolarize. All right, so we got to use our electrical words. But if we want to simplify it out, the P wave represents our atria doing what it's supposed to, contracting. Our QRS is representing our ventricles doing what they are supposed to do, and contracting. And the T wave represents a rest of the whole process. Okay? So that is the extremely simplified version. But we have to remember, this is all electrical. It's electrical, electrical, electrical. Okay? So, let's add a few more of these things in here. So when we look at a rhythm, we have to do a lot of evaluating to determine what's going on with the rhythm. So the first thing, I've kind of given it to you in an order. I should have put baseline right at the top rather than rate, but I want to look at my baseline. This should look like somebody drew it with a ballpoint pen with a very steady. It should not look like somebody who drank too much Red Bull is drawing it, okay? Because that's some false reading. We'll have a vocabulary word for that in a minute. It shouldn't look like stereo waves with like it's really big and fat. Like it should look like a fine ballpoint line. It should be on a baseline. It shouldn't do like this on the graph paper. Okay, it should be a baseline. So that's kind of just our standard of interpretation. If it's not, we need to maybe change the leads out and get a better reading. All right, so if I look at rate, I want to count my QRS complexes. So how many do you have? On your 6-second strip. You have 8. You have a 6-second strip. So if you multiply that by 10, that'll give you 60 seconds. So you'll have a minute. So 8 times 10 is 80. That's your heart rate. That is the easy way to calculate your heart rate.
So count the QRS complexes.
Count your QRS complexes. And this is a 6-second strip, so if you multiply it by 10, that gives you your 1-minute heart rate.
So even though we're gonna multiply by 10?
Yep. That's why I'm telling you, I am giving you 6-second strips. Like if you go to Clinical and you print out a strip, there's a way to cut it to 6 seconds. Like it's clearly marked. You're like, okay, you're here, there's 6 seconds.
So, okay, everybody does it. 6 seconds.
No, it's very clear on how you can cut 6 seconds. If you have just like a continuous printout, very easy to know where to cut it. So that's why I'm telling you, all the strips I give you are gonna be 6 seconds, even if they don't look like it, because I steal all these off of Google. So, I'm cutting them the way I want to cut them to make the rhythm I want. So, all are 6 seconds. To get your rate, count your QRSs, multiply by 10. Alright, so it's 80. Am I in my normal heart rhythm? Yep, so I don't have any words I can use yet because I can't use tachycardia or bradycardia because I have a good rate. So far nothing. My next one, regularity. Are my QRSs spaced out evenly? That's what the word regular means. So from here to here, is this space the same each and every time? Is it regular? Is it regular?
Yes.
Yes. Cool. Still don't have anything else I can say because we followed all my rules. Everything's good so far. The next thing on here, P wave. All right, so I'm gonna give you some characteristics of P waves. I should have a P wave for every single QRS. Every one. Because the SA note is supposed to start this show, right? So every single time I should have a P wave. You got one?
Yeah.
Alright, good. Things about the P wave. It should be rounded and pointing up if you're looking at a standard interpretation. It should just be there because there's some rhythms where it's not there. So it should just be there, should be rounded, should be pointing up. So if you have a P wave for every single QRS, we get to use our vocabulary word, sinus. So right now, this is a sinus rhythm. As long as he doesn't break any more of my rules, he gets to keep that. Okay? But if he breaks a rule, he's not going to get to keep it. All right, my QRS complex. My QRS complex should be within a big box. So this is my first big box rule. So my Q starts here. RS is all contained within a big box. It doesn't go outside of the big box. So my QRS complex should be contained within one big box. It actually should be smaller. So if you read in your book that it should be smaller than 0.2, you're right. I'm just giving you the down and dirty. Okay? Should be within a big box. Cannot go outside of a big box. I will show you examples of ones that go outside. But right now, my QRS complex should be very narrow. So we call this a narrow complex QRS. If it goes outside of a big box, we will then call it a wide complex QRS, which are abnormal, which we don't want to see. We want a narrow QRS complex. So the reason I can say it's narrow is because it fits within a big box. Alright, so he didn't break my rule, so he gets to keep his name so far. Alright, the next thing on here is my PR interval. Alright, let's go with this one. So you're going to find a P wave that lines up with a big box. See, this one's perfect. I don't want to do this one because, and I don't want to do this one. This one's good. I can use this one too. That P wave starts right at the big box. So I'm going to pick one that lines up that I can see it the easiest. The P to the Q is actually my PR interval. Why they name it PR, I don't know. But it is actually from the P to the Q. Should fit in the big box. So from the start of your P wave to the Q, that is your PR interval, and it should fit within the big box. Does he fit in the big box? Yep. So he didn't break my rule. If he breaks my rule, he loses his name. He ain't broke my rule, so we're good. So my PR interval stayed in the big box. Yes. T wave all the way to the Q.
Should be in a big box.
Should be in the box. It is called a PR. You got it. I don't know why they didn't call it a PQ interval. That would be too easy.
You said it would be less than 0.2 seconds.
So it's within the big box. Alright, so those are my two big box rules. Your QRS on its own should fit in a big box. Your PR interval on its own should fit in a big box. Those are two separate things I'm looking at. Don't try and smush them all together, okay? Two separate things. Because I want a narrow complex QRS, and I want a PR interval that fits in a big box, because we're gonna have rhythms that break those rules. So those are my standards I want to see. All right, and then my T wave. So for 114, we are not going to evaluate the T wave, because that is going to get into advanced. That's where you start learning about different types of heart attacks. You see heart attacks on T waves. That'll be 211, okay? So for us in 114, we're just going to say, yep, I see one, cool. It's there. And you'll learn more about evaluating various types of heart attacks with the T wave until then. All right, so I have a P wave for QRS. I have a normal rate. So what's this rhythm? Sinus rhythm. That's it. If I gave you this exact same rhythm strip, but I told you the heart rate was 40, what would this rhythm be? Sinus bradycardia. If I gave you this exact same strip, but the heart rate was 115, what would it be?
Sinus tachycardia.
Sinus tachycardia. You know 3 rhythms. Yep. It's a lot of dysrhythmia knowledge is knowing what everything means and your vocabulary. I'm going to give you more vocabulary words, okay? But you got to know what your vocabulary words are. So that is your basic. Here's what all these waves mean. We're going to follow a very strategic pattern of evaluating the rhythms. And I'll tell you what when rules are broken, I'll give you the vocabulary word for the rule is broken. Okay? All right, so let's look at a 12 lead. Just all I want you to know for a 12 lead. Oh, then it should just be straight. It should look like a ball point.
Oh,
okay. Yeah, no. So what I've taught you already is you were just looking at one lead. Okay? That was just one lead. This is an example of a 12 lead EKG. All I want you guys to know about a 12 lead EKG is that I am getting views from all around the heart. So I'm getting a 360 view of the heart. When you guys are looking at just one lead, you're getting one view of the heart. So we typically evaluate in lead 2, which is right here. So this looks similar to what we have on our sheet, right? This is lead 1, this is lead 2, this is lead 3. Looky here at lead AVR. Everything's flipped upside down because I'm looking at the heart in a different view. So this is a variation of normal. It's just looking at the heart in a different direction. But the QRS is pointing down in that lead. The QRS and AVL is going up and down. So those are all, I'm looking at the heart in a different angle. Okay? So why in the world do I do this? So I get to pick on Hannah. Whoever sits here is always my pick on person. So I get to pick on Hannah right here. So if I look at Hannah, can I tell if Austin or Kasumi got real mad and stabbed her in the back with a pencil? I don't know. Y'all can, but I can't see it. So I can't see damage behind her. If I go around to the back of her, suddenly she doesn't have a face. Does she still have a face? Yep, still has a face, but I can't tell if she's got punched in the face and has any damage to the front of her face. So this is why I do a 12-lead EKG. Because in this view, if you look right here, does this look normal from what we've seen? No? crazy things are happening, and it looks bad. It's actually what a heart attack looks like. But the whole point of a 12 lead EKG is that we have to look all the way around the heart. So when we start learning about coronary artery disease, we're gonna talk about 12 lead EKGs a lot. That is all you need to know at your level about a 12 lead EKG. That is
Thank God.
looking at different views of the heart. So remember when we had the picture of the coronary arteries? You can look at, not you, but if you're trained. I have not gone through the certification class, so I can't tell you. I'm sure Bridges can tell you, because she's your cardiac expert person. But you can look at a 12 lead EKG and specifically say the RCA is included, the LAD is included, the circumflex is included, like based on which lead is showing damage. So your cardiologist can look at it and say, I know exactly which coronary artery is included. So that's why we do these. So for us, just make sure it looks good. Prints. Here. That's it. All right, some terms. We're gonna go over all these terms at some point. So I'll go ahead and tell you what some of them mean, not all of them. Artifacts. Here's examples of artifacts. Artifact means false reading. Does that look like a nice ballpoint line? No. Can you tell on that top one if there's a P wave? Not really. Can't see it, so I cannot read that. That is artifact. Second one, and it's supposed to be straight across. That one's wavy. Can't read that. Nope. Artifact. This one down here at the bottom looked pretty good for a while, but then it looks like somebody picked up the cord and went and squiggled it for a minute. These are all examples of artifact. How do you fix it? All right. Quit wiggling. Be still. So if somebody's like very animated while they're talking, like I tend to be, or like if they're shivering because they're really cold, they're gonna have artifacts. If they're sweaty and it's kind of, the leads are coming off, so I may need to change my leads because maybe they're sweaty and they're coming off. Maybe the gel has dried out because they've been on the chest for too long. It's a good idea just to change all the leads with a bath. So every time you give a bath, just get new leads on them. Because that gel does dry out and you end up with that one up top. This one in the middle tends to be my sweaty, hairy people because the leads are hanging on. So, point, don't evaluate artifact. Agonal, this is actually a rhythm that we'll see later, but think of this as like a DNR patient. Like the heart is giving its last few little beats. So agonal is a rhythm we'll see later. Demand pace, I'm gonna save that for later because that's to do with pacemaker. Paroxysmal. This word means starts and stops on its own. So paroxysmal, starts and stops on its own. So no intervention from us. Have any of y'all felt your heart like flutter for a little bit and then it kind of stopped? Then you had a paroxysmal event because it started and stopped on its own. So we see patients who have like a little bit of a rhythm change and then before we can ever do anything about it, it went away and you're like having to run back to the computer and go find it to print it out to show the doc what happened. That they had a paroxysmal run of something. So palpitations is more of a feeling as opposed to an electrical situation. So I'm referring all this as like a so palpitations is a subjective feeling. Depends. Are you having palpitations because you're having an electrical problem, or are you having palpitations because you're having a heart valve problem? Like, because palpitations is subjective feeling. So I need to find out, is it an electrical issue or do an echo and find out if it's a valve issue? So any complaint of palpitations, I gotta find out what's causing it. Pause is exactly what it sounds like. You just have a pause in your electrical conduction. This happens a lot with hormone changes. So ladies, teenage years where hormones are just kind of all over the place, pregnancy when hormones are all over the place, and then perimenopause again. So basically our entire lives, ladies. We can have pauses, so not significant, but it can be enough to cause some irregularity in our heart rhythm that's hormonal based. And then if you have other types of issues, so my brother actually had to just wear a heart monitor for 2 weeks, and he called me and told me like what they actually had, like he had a 2.5-second pause. We don't know why. So that's one of the things that we're gonna look at, because we're gonna show some examples of pauses. PEA, we'll talk about it later, and you can go in there right now. RLT phenomenon, ain't going there right now, we'll do that later. Run, we'll do that later. You need more context to get that. All right, so we're not gonna do treatments today, but just, this is where I'm thinking of for treatments. For treatments, our goal of any dysrhythmia is gonna be optimized cardiac output. So we've already drawn kind of a picture of somebody that has decreased cardiac output, so we wanna optimize it. Our priority is gonna be assessment, assessment, assessment. So from now until the end of the semester, because I've got you for perfusion and medical emergencies, assessment, assessment, assessment. We're gonna beat this dead horse. Assessment. We're gonna assess before we intervene. We're gonna find out if our patient is symptomatic or non-symptomatic. Fred is symptomatic. A lot of these rhythms, there's prevention. So as we go through them, we're gonna look for ways to prevent them. And then some of these rhythms are gonna need long-term therapy, so we'll go through those. So that's kind of where I'm gonna go with treatments, but we're gonna do that next week. Let's just look at the rhythms right now. All right, so let's start evaluating rhythms. We're gonna go through our systematic approach and we're gonna label them. So let's start out, first step, what's the rate?
40.
40, okay? Baseline, it's all okay, right? Everything look good on baseline. What, do you have a P wave for every QRS?
Yes.
So what word can I use?
Sinus.
Sinus. Does my QRS fit in a big box?
Yes.
Does my PR interval fit in a big box?
Yes.
Okay, no rules have been broken, and it's regular. I don't think, did I ask that, if it's regular or not? It's regular. So what is this rhythm?
Sinus bradycardia.
Sinus bradycardia. That's it. We interpreted a rhythm.
The T wave does not matter.
For us, no, it's there. We're not looking at the T wave yet. Actually, I'm gonna point out one thing. It's not here, but what do y'all know about a T wave? What should it look like?
Not rounded, not rounded.
It should be rounded, it should not be peaked. And it should not be
Inverted.
tall. It should not be tall. Because remember we said tall tinted or tall peaked T waves? Because what is that indicating?
Hyperkalemia.
Hyperkalemia. So y'all already knew that, so now it's just, that's what a T wave is supposed to look like. Or like what it is on your strip.
Yes.
So when we're looking at height of a T wave, it should, you gotta compare it to the QRS, it should be less than half the height of the QRS. So like this one, as long as it wasn't about right here, so even if it was up here, I'd still say it was okay, but it wouldn't, I don't want it to be as tall as the QRS. So when we say tall, we're comparing it to the QRS. I'm gonna show y'all some tall ones. Like we'll have some tall ones on there. Okay, let's look at this rhythm. Somebody count it and tell us the rate.
110.
110, so what word does it get? It gets tachycardia already, okay? Is it regular? Yep. It's a little fast, but it's regular. Do I have a P wave for every QRS?
Yes.
I do, so what word does it also get?
Sinus.
Sinus, so far we're sinus tachycardia. Are my big box rule, is it broken?
No.
Nope, QRS is within a big box?
Yes.
PR interval is within a big box?
Yeah.
No rules broken? I got a T wave, so
Yes.
this is
Sinus tachycardia.
sinus tachycardia. So this one, this is the big box. not looking at height, I'm looking at width.
Oh, gosh.
Oh.
You
I say, you just did this, and I was like,
I was like, that is not in the same boat, y'all are all crazy.
Width, not height, width.
It looks a lot different.
It does look a lot different.
It's just because
It's because it's fast.
Good, I didn't want to do anyone else.
All right, so any questions? Okay, have to stay on break if you're scared to, that's fine. All right, so those are we have 3 sinus rhythms. We've got sinus rhythm, sinus brady, sinus tachy. Okay, so we know, we can identify those. All right, so now we're gonna get into some rhythms that are gonna break some of my rules. So I'm gonna give you some new vocabulary words, okay? So typically, I've kind of grouped them into these categories. If you have a problem with the P wave or the baseline, it's gonna be an atrial issue. If you have problems with the QRSs, it's gonna be a ventricular issue. For the most part, our ventricular issues are gonna start going into our lethal rhythms. So for this perfusion test, I'm going to test you on recognizing all the rhythms. So you're gonna have to recognize all of them. But specifically the treatment for lethal rhythms, and we'll save that for medical emergencies. Because obviously a lethal rhythm is a medical emergency. So I kind of split up how I'm testing you on rhythms so that it's spread out between 2 tests, rather than just like hitting you all at once with everything. Okay? So let's start with atrium. So we have 3 rhythms we're gonna learn with atrium. So we've got supraventricular tachycardia. So supra means above. So above the ventricles, tachycardia. Well, what's above the ventricles? The atria. So supraventricular tachycardia. So somewhere up here is a problem. And then we have atrial fibrillation and atrial flutter. And y'all heard of those rhythms, right? Yeah, so those are pretty common in culture now. So let's look at the first one. All right, so we gotta identify what's wrong. So first off, who's gonna count it and tell us what our rate is? What is it?
160.
Is that right? 160. I'm going with it. Y'all can count it. Y'all can count it on your screen a lot easier than I can count it up here on this projector. All right, so my rate's 160. Well, that is very fast. So, tachycardia. All right, is it regular? It is. It's regularly fast, but it's regular. It's regular. It's very fast. Do I have a P wave for every QRS?
Yes.
Do you know that's a P wave and not a T wave? Can you tell that you have a P wave and a T wave? Ooh.
No.
Okay, if you are unsure if it's a P wave or a T wave, the answer is no, you don't have a P wave. You should, without a shadow of a doubt, 100% be able to say that is a P wave and that is a T wave. And if you can't say that, the answer is no. Because I'm not real sure. I've only got one wave pointing up, and aren't both waves supposed to be pointing up? Your T wave and your P wave supposed to be pointing up? So this is too fast for me to tell. It's too fast. So I have no P wave, so what word can I not use? Sinus. I can't use that word now. It's whoop, out the door. All I've got is tachycardia. All right, big box. Is my QRS in a big box?
Yes.
Yep, so I have a narrow complex QRS, so that's good. That means my ventricles are doing what they're supposed to do. Okay, PR interval, can I evaluate it?
No, you
I can't evaluate it, so I'll have a P wave without a shadow of a doubt P wave. So all I can say for this rhythm, my ventricles are fine, but somewhere above the ventricles are acting a fool. So what was our word for above the ventricles? Supraventricular tachycardia. So this is SVT. Alright, so characteristics of SVT. As we've said, the rate's really fast. It's typically 160 and above. And you can see this rhythm go all the way up to 200. So we can be very, very fast. a narrow complex QRS. Narrow complex, so my QRS is fitting in that big box. And it's typically regular. So I don't see a P wave. I don't see a P wave. I can't tell if it's a P wave or a T wave, or is it some mash of the two? It's too fast for me, so let me show you. Sorry, wrong direction. Okay, you see how on this one, I can 100% tell that is a P wave and that is a T wave. I see two waves in between that QRS, like very clearly. But on, shoot, I'm going the wrong direction. Sorry, don't have a seizure, nobody. But you see on this one, I don't see two waves. Is it a P wave, is it a T wave? I don't know. So this is gonna be, all I can say is supraventricular. Somewhere up here is causing a problem. So supraventricular tachycardia. So I need to slow this down to evaluate it further and see what's going on. We'll do all that treatment next week. We're just recognizing today. All right, let's look at our next one. What is our rate? At 90? All right, I got no words right now. Okay, is it regular?
No.
Ugh, it is very irregular. Okay? Irregular. Very irregular. Irregular.
Okay.
It's irregular. Cause y'all heard that, right? Irregular rhythm. So regular rhythm, irregular rhythm. It is awful. None of those are spaced in any shape close to each other. All right. Do you have a P wave for QRS? Okay, remember what I said. You have to be 100% sure every single time. And if you are not 100% sure every single time, the answer is?
No.
No, there is no P wave. Because I can kind of squint my eyes and maybe pick two P waves out of there, so the answer is no. There's no P wave. I still have no words to give this rhythm. Okay. Is my QRS in a big box?
Yes.
Okay, so my ventricles are doing fine. My ventricles are good. I'm not worried about them. So somewhere I'm having a problem up in my atria. So I have a narrow complex QRS, so I'm happy. Can't do a PR interval because it ain't there. All right, so tell me what else you see on this rhythm. It's squiggly. All right, it looks like again, somebody wasn't quite steady, drew this line. So the baseline is very chaotic and gibberishy. So I have a word for that. It's called fibrillating. So my baseline is fibrillating. So I've already said my ventricles are fine, right? So who is fibrillating? My atria. So this is atrial fibrillation. AFib. All right, so your vocabulary word, fibrillate. Fibrillation means a chaotic, gibberishy, crazy baseline. Now, for some reason on the test, I have students struggle to determine who is fibrillating. Is it the atria or is it the ventricles? Okay, that is one of the most commonly missed things that I see on this test that y'all get it mixed up. If you have a narrow complex QRS in there, my ventricles are doing what they're supposed to. They are fine. So the only thing that's causing a problem is up in the atria. It's fibrillating. So this is atrial fibrillation. So what's actually going on in the atria? So who's supposed to start us out? SA note. So in AFib, you've got all these other little turds trying to take over and be the boss. So you have all of these impulses atria.
What are those called?
They're just very
Doesn't matter.
irritated little sections
Okay.
of the heart, so they don't specifically have a name.
Okay.
But every single fiber of your heart can trigger a beat. So when we get into like a little bit further on into, this is how like electrolyte imbalance can cause problems. So you've got all these other little sections in the atria that are trying to take over and be the boss. And they're sending out all these impulses. Now the AV node is trying its hardest to only listen to the SA node. So it's trying to filter through all these extra impulses. So that's why you get all this waviness, and that's why you get such an irregular ventricular rhythm, because the AV node is trying to block out all the noise and just find the SA node, but it ends up being very irregular because of that. So one of the big problems of AFib is what if the AV node is just like, I'm tired, I give up, all y'all, come on, and starts transmitting all of these. What's gonna happen to your heart rate? It's going to increase. So one of the problems with AFib is they can suddenly, for no reason whatsoever, they can be sitting there watching TV, drinking water, and their heart rate will go from 80 to 280 with no trigger. It's all because the AV node gets exhausted and just is like, I can't do it anymore, and just starts transmitting all of the beats. So one of the big issues with AFib is tachycardia. Suddenly go into tachycardia for no reason. All right, let's talk about the other big issue of AFib. So all these impulses are sending, which means your atria is depolarizing at a rapid rate, so your atria is not actually going, it's not an organized contraction. So your atria is fibrillating, it's sitting here doing like this, it's quivering. So, do you ever fully eject the blood out of the atria? No, because it's just sitting here quivering. So what happens to blood when it doesn't move?
It's backed up.
It's backed up and it pools. What does blood do that just pools and sits? It clots. AFib, huge clot risk. So those are the two main issues I want you to know with AFib. You can go to tachycardia for no reason whatsoever, just spontaneously. And they're a huge clot risk. Because you've got multiple electrical signals coming in, so you never actually get an organized contraction. You get different parts of the muscle contracting at different intervals. So you get blood clots. So what test am I gonna do for an AFib patient to see if they got blood clots in their atria? Echocardiogram. That's the test I can see for blood clots. So if you watched a TEE, probably were watching a patient who was in AFib. So we're probably about to get their AFib corrected. So we'll talk about that with the treatment next week. All right, let's look at our. We're very close. All right, let's look at this one. What's my rate? 60, no words for it. All right, is it regular?
Yes.
This one's regular. Okay. Do I have a P wave for every QRS?
Don't know.
I don't know, because there's a lot going on in there. So I don't know if that's a P wave or not. So I can't say that, I can't say for sure. Does my QRS fit in the big box? Yep, so again, my ventricles are behaving. I got a narrow complex QRS, I'm happy. Can't do a PR interval because it's not there. There's a lot going on there with the T wave, I don't know. So I've got extra waves. All right, these extra waves are very regular and they look uniform. So these are called flutter waves. Flutter waves have a sawtooth pattern, like the flap of a butterfly wing. So those are all the different ways that these waves are fluttering. The atria is fluttering. So with AFib, you have a whole bunch of little turds throwing off impulses. Aflutter, it's just one little guy causing a problem on a regular basis. So aflutter and AFib are basically what we treat them the same. People go in and out of AFib and aflutter, like they go back and forth. I've got a rhythm up here of somebody going back and forth between AFib and aflutter every 1 second.
Jeez.
Yep, so the lady that I had, and if you wanna come see it, you can come up here, I'll show it to you in a little bit. I had all my students, it was a rapid response, I had all my students lined up along the corner of the room, you know, you gotta get in where you can't get kicked out. And we were all watching her rhythm, and we were all hitting each other going, fib, flutter, fib, and she was just going in and out of AFib and aflutter that quickly. So these rhythms, they're sisters. We treat them exactly the same. Everything I said about the tachycardia and about the clotting, all of it goes to aflutter too. If you can't tell the difference between AFib and aflutter, don't get too hard on yourself, because honestly, like, they're the same.
So it's atrial, the QRS is within of it. So if it was widened, we would have an atrial. We're gonna see.
So, the only difference between AFib and aflutter is one problem child in atria. AFib is a lot of problem children. 1:30. Okay, so let's take us a break before we do our ventricular rhythms.